EKG strips can feel overwhelming, but what if I told you that in just 5 minutes, you could break them down so easily that even the trickiest rhythms start making sense? In this video, I'm going to show you the simple step-by-step method to master EKG interpretation the NCLEX way. Stick with me till the very end, because I'll also share insider strategies that top students use to avoid mistakes and pick the right answer every time. By the end, you'll feel confident, fast, and ready to crush those cardiac questions on test day. Question 1. A 6-second strip shows RR intervals occurring 12 times. What is the ventricular rate? A. 60 beats/min. B. 100 beats/min. C. 120 beats/min. D. 150 beats/min. Answer: C. 120 beats/min. Rationale: counting R waves on a 6-second strip and multiplying by 10 estimates rate. 12 R waves times 10 is equal to 120 beats/min. Strategy: if the rhythm is regular, you can also use the large box method, but the 6-second method is fastest on NCLEX. Multiply by 10 only when the strip is exactly 6 seconds. Question 2. A strip shows regular P waves before every QRS, PR interval 0.16s, QRS 0.08s, rate 78. What rhythm is this? A. Sinus bradycardia. B. Normal sinus rhythm. C. Sinus tachycardia. D. First-degree AV block. Answer: B. Normal sinus rhythm. Rationale: normal PR is 0.12 to 0.20s and QRS less than or equal to 0.10s with P before each QRS, rate 60 to 100. Strategy: memorize anchor normals, PR 0.12 to 0.20s, QRS less than or equal to 0.10s, QD 0.36, 0.44s, rate dependent. If all are normal, pick normal sinus rhythm. Question 3. A client's rhythm shows no P waves, irregularly irregular RR intervals, and a narrow QRS. What is the rhythm? A. Atrial flutter. B. Atrial fibrillation. C. Ventricular tachycardia. D. Sinus arrhythmia. Answer: B. Atrial fibrillation. Rationale: absence of organized P waves with chaotic baseline and irregularly irregular ventricular response is hallmark for atrial fibrillation. Strategy: irregularly irregular almost always points to atrial fibrillation on NCLEX unless otherwise specified. Question 4. A strip shows sawtooth flutter waves at a rate of 300/min with a ventricular rate of 150 per minute and narrow QRS. What rhythm is this? A. Atrial flutter with 2:1 block. B. SVT. C. Ventricular flutter. D. Junctional tachycardia. Answer: A. Atrial flutter with 2:1 block. Rationale: flutter waves, F waves, at 300 with every second flutter conducted gives ventricular rate 150. Strategy: if you see sawtooth, consider flutter, divide atrial rate by conduction ratio to get ventricular rate. Question 5. Which ECG change is most consistent with hyperkalemia? A. U waves. B. Peaked T waves. C. Prolonged QT interval. D. ST depression with sagging. Answer: B. Peaked T waves. Rationale: hyperkalemia classically causes tall, peaked T waves, widened QRS, and can progress to sine wave. U waves suggest hypokalemia. Prolonged QT suggests hypocalcemia or drugs. Strategy: tie electrolytes to signature waves, hyper K equals peaked T, hypo K equals U waves, hypo Ca equals long QT. Question 6. A regular narrow complex tachycardia at 190 per minute with buried P waves is most consistent with A. Atrial flutter. B. SVT, AVNRT. C. Ventricular tachycardia. D. Sinus tachycardia. Answer: B. SVT, AVNRT. Rationale: very regular, narrow QRS, often with P waves hidden in or just after QRS suggests AV nodal reentry. Strategy: rate greater than 150, narrow QRS, very regular equals think SVT unless clear flutter waves are present. Question 7. Appropriate initial medication for stable narrow complex SVT is A. Amiodarone 4 bolus, B. Adenosine rapid 4 push, C. Epinephrine 4 push, D. Magnesium sulfate 4. Answer: B. Adenosine rapid 4 push. Rationale: for stable, regular narrow complex SVT, vagal maneuvers then adenosine are first line. Strategy: identify stable, no hypotension, chest pain, altered mental status, shock, or acute HF. Stable narrow complex SVT adenosine. Question 8. A rhythm shows wide QRS complexes at 160 per minute, no visible P waves, and monomorphic appearance. The patient is pulseless. Which action is priority? A. Synchronized cardioversion, B. Defibrillation, C. Atropine 4, D. Adenosine 4. Answer: B. Defibrillation. Rationale: pulseless VT is treated as a shockable cardiac arrest rhythm with immediate defibrillation and high-quality CPR. Strategy: pulseless equals defibrillate 4 VF/private. Synchronized cardioversion is for unstable with a pulse. Question 9. Which description matches ventricular fibrillation? A. Organized wide complex rhythm without P waves. B. Chaotic, irregular baseline with no identifiable QRS. C. Regular narrow complex tachycardia at 180 per minute. D. Regular rhythm with prolonged PR interval. Answer: B. Chaotic, irregular baseline with no identifiable QRS. Rationale: VF shows disorganized electrical activity with no discernible P, QRS, or T. It is a shockable arrest rhythm. Strategy: if you can't find consistent QRS or RR, think VF. Question 10. What is the first-line intervention for unstable atrial fibrillation with rapid ventricular response and hypotension? A. Adenosine 4 push, B. Synchronized cardioversion, C. Atropine 4 push, D. Vagal maneuvers. Answer: B. Synchronized cardioversion. Rationale: unstable tachyarrhythmias require synchronized cardioversion when a pulse is present. Strategy: the presence of hypotension or altered mental status in tachyarrhythmias pushes you to synchronized cardioversion. Question 11. The PR interval is 0.24 s and constant with each beat. What rhythm description is correct? A. Second-degree AV block type I, B. First-degree AV block, C. Second-degree AV block type 2, D. Third-degree heart block. Answer: B. First-degree AV block. Rationale: uniformly prolonged PR greater than 0.20 s with every P conducted indicates first-degree AV block. Strategy: constantly long PR equals first-degree, progressively longer then dropped equals Mobitz I, fixed PR with random drops equals Mobitz 2. Question 12. Progressive PR lengthening until a QRS is dropped best describes. A. Mobitz 2 block, B. First-degree block, C. Third-degree block, D. Mobitz I, Wenckebach. Answer: D. Mobitz I, Wenckebach. Rationale: classic pattern is longer, 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 drop. Strategy: mnemonic, Wenckebach winks before it drops. Question 13. Fixed PR intervals with sudden non-conducted P waves and dropped QRS complexes describe. A. Mobitz 2 block, B. Mobitz I block, C. First-degree block, D. Sinus arrest. Answer: A. Mobitz 2 block. Rationale: constant PR with unexpected drops indicates a more serious infranodal block risk for progression to complete heart block. Strategy: on exams, Mobitz 2 often calls for pacing readiness due to instability risk. Question 14. P waves and QRS complexes are present but bear no consistent relationship. Atrial and ventricular rates are independent. What is this rhythm? A. Junctional rhythm, B. Third-degree heart block, C. Sinus arrhythmia, D. Atrial flutter. Answer, B. Third-degree heart block. Rationale: AV dissociation with independent atrial and ventricular activity defines complete heart block. Strategy: look for marching P waves and marching QRS that don't align, think complete heart block and anticipate pacing. Question 15. Appropriate immediate treatment for unstable bradycardia with hypotension is: A. Atropine 4. B. Adenosine 4. C. Amiodarone 4. D. Magnesium sulfate 4. Answer, A. Atropine 4. Rationale: atropine is first line for symptomatic bradycardia. If ineffective, consider transcutaneous pacing, dopamine, or epinephrine infusion per ACLS algorithms. Strategy: brady plus bad perfusion atropine, then pace if needed. Question 16. A QRS duration of 0.14 s indicates: A. Normal ventricular depolarization. B. Narrow complex tachycardia. C. Bundle branch block or ventricular origin. D. Artifact. Answer, C. Bundle branch block or ventricular origin. Rationale: QRS 0.10 to 0.12 s suggests conduction delay or ventricular rhythm. Strategy: if QRS is wide, ask, is it VT, BBB with supraventricular rhythm, or paced rhythm? Question 17. A client with digoxin therapy shows downsloping ST depression, scooped ST, and flattened T waves but is asymptomatic. The nurse should: A. Stop the drug immediately. B. Recognize expected effect and monitor. C. Give potassium immediately. D. Prepare for synchronized cardioversion. Answer, B. Recognize expected effect and monitor. Rationale: digoxin effect causes characteristic STT changes without toxicity symptoms. Toxicity signs would include bradyarrhythmias, AV blocks, and GI/visual symptoms. Strategy: distinguish effect from toxicity by symptoms and rhythm instability. Question 18. Which lead grouping localizes an anterior wall STEMI? A. 2, 3, AVF. B. V1, V4. C. I, AVL, V5, V6. D. V7, V9. Answer, B. V1, V4. Rationale: V1, V4 view the anterior wall supplied primarily by the LAD. Strategy: memorize MI territories, inferior, 2, 3, AVF, anterior, V1, V4, lateral, I, AVL, V5, V6, posterior, V7, V9 with reciprocal V1, V3. Question 19. The nurse sees tall R waves in V1, V2 with ST depression and upright T waves in these leads during chest pain. This most likely represents: A. Normal variant. B. Posterior MI with anterior reciprocal changes. C. Early repolarization. D. Pericarditis. Answer, B. Posterior MI with anterior reciprocal changes. Rationale: posterior infarction shows reciprocal tall R and ST depression in V1, V3, posterior leads would reveal ST elevation. Strategy: if V1, V3 show ST depression with tall R waves during ischemic symptoms, think posterior MI and request posterior leads. Question 20. Global ST elevation across many leads with PR depression is most consistent with: A. Pericarditis. B. STEMI. C. Hyperkalemia. D. AVNERT. Answer, A. Pericarditis. Rationale: diffuse ST elevation with PR depression and absence of reciprocal ST depression, except AVR/V1, suggests pericarditis. STEMI is usually territorial. Strategy: diffuse and PR down points to pericarditis. Question 21. Which is the best quick method to calculate rate for irregular rhythm when you have a full grid? A. Count small boxes between R waves and divide 1500 by that number. B. Count R waves in 3 seconds and multiply by 5. C. Count large boxes between R waves and use 300-150-100-75-60-50 sequence. D. Estimate by eyeballing. Answer, C. Count large boxes between R waves and use 300-150-100-75-60-50 sequence. Rationale: the 300 method is the fastest for regular rhythms on typical exam strips. Strategy: if the rhythm is irregular, switch to the 6-second method. Question 22. A strip shows regular P waves with inverted P morphology and a narrow QRS at 40-60/min. What rhythm is suggested? A. Junctional rhythm. B. Sinus bradycardia. C. Idioventricular rhythm. D. Atrial flutter. Answer: A. Junctional rhythm. Rationale: junctional rhythms arise from the AV junction with rates 40-60/min. P waves may be inverted, absent, or after the QRS. Strategy: rate range clues, junctional 40-60, idioventricular 20-40 and wide QRS. Question 23. A wide complex rhythm at 30 per minute without P waves is most consistent with A. Junctional rhythm. B. Sinus bradycardia. C. Idioventricular rhythm. D. Atrial fibrillation with slow response. Answer: C. Idioventricular rhythm. Rationale: ventricular escape rhythm produces wide QRS at 20-40/min with absent P waves. Strategy: very slow plus wide plus no P. Idioventricular, anticipate decreased perfusion and pacing needs. Question 24. Which is true about asystole? A. It is shockable. B. Confirm in 2 leads and start CPR and epinephrine. C. Give adenosine immediately. D. Synchronized cardioversion is preferred. Answer: B. Confirm in 2 leads and start CPR and epinephrine. Rationale: asystole is non-shockable, verify that it's not fine VF, begin high-quality CPR, and administer epinephrine. Strategy: always verify in more than 1 lead before labeling asystole. Question 25. The initial nursing action for pulseless electrical activity, PEA, is A. Defibrillation. B. Synchronized cardioversion. C. High-quality CPR and epinephrine. D. Adenosine. Answer: C. High-quality CPR and epinephrine. Rationale: PEA is non-shockable, treat with CPR, epinephrine, and search for reversible causes, HS and TS. Strategy: remember PEA equals pump problem despite tracing, so no shock. Question 26. A paced ventricular rhythm will show A. Narrow QRS with normal P. B. Wide QRS with spikes preceding QRS complexes. C. Irregular baseline without QRS. D. Only P waves. Answer: B. Wide QRS with spikes preceding QRS complexes. Rationale: ventricular pacing produces a pacing spike then a wide QRS. Strategy: atrial pacing shows spike before P, dual chamber pacing shows 2 spikes. Question 27. A patient with a history of WPW presents with a narrow complex SVT at 190 per minute, stable. The nurse anticipates which medication? A. Adenosine rapid 4 push. B. Verapamil 4. C. Digoxin 4. D. Propranolol 4. Answer: A. Adenosine rapid 4 push. Rationale: for stable narrow complex reentrant tachycardia, adenosine is appropriate. Avoid AV node blockers in atrial fibrillation with WPW, but for regular narrow SVT adenosine is first line. Strategy: confirm the rhythm is regular, narrow, and not pre-excited AF before choosing adenosine. Question 28. You note marked artifact during patient shivering. What should you do first? A. Call a code. B. Replace the monitor. C. Warm and reassure the patient and check electrode adhesion. D. Start amiodaron. Answer: C. Warm and reassure the patient and check electrode adhesion. Rationale: muscle activity causes artifact, address patient factors and electrode contact before assuming arrhythmia. Strategy: on exams, rule out artifact when the tracing looks noisy but the patient is asymptomatic. Question 29. A sinus tachycardia at 110 per minute appears during pain. The priority is A. Prepare for cardioversion. B. Treat the underlying cause. C. Give adenosine. D. Administer atropine. Answer: B. Treat the underlying cause. Rationale: sinus tachycardia is a physiologic response. Treat pain, fever, hypovolemia, or anxiety rather than rhythm-targeted drugs. Strategy: if the rhythm is an appropriate response, fix the trigger first. Question 30. A QTC markedly prolonged with torsades de pointes episodes indicates the nurse should anticipate A. Adenosine. B. Magnesium sulfate 4. C. Atropine. D. Digoxin. Answer: B. Magnesium sulfate 4. Rationale: torsades, polymorphic VT with long QT, is treated with magnesium and correction of precipitants, electrolytes, drugs. Strategy: twisting points plus long QT equals magnesium. Question 31. A patient with inferior STEMI will most likely have ST elevation in A. I, AVL. B. 2, 3, AVF. C. V1, V4. D. V5, V6 only. Answer: B. 2, 3, AVF. Rationale: inferior wall is represented by limb leads 2, 3, and AVF. Strategy: associate I and AVL with high lateral, V5, V6 with low lateral. Question 32. Which finding is classic for hypokalemia? A. Peaked T waves. B. U waves and flattened T waves. C. Diffuse ST elevation. D. Prolonged PR interval only. Answer: B. U waves and flattened T waves. Rationale: hypokalemia produces U waves, flattened T waves, and may cause ventricular ectopy. Strategy: electrolyte patterns are high-yield memorization. Question 33. A nurse identifies a regular rhythm at 35 per minute with narrow QRS and no visible P waves. Blood pressure is 70/40 mmHg. What is priority? A. Atropine and prepare for pacing. B. Adenosine. C. Defibrillation. D. Amiodarone infusion. Answer: A. Atropine and prepare for pacing. Rationale: symptomatic bradycardia with hypotension requires atropine. If ineffective, transcutaneous pacing is indicated. Strategy: any bradycardia with poor perfusion atropine, then pace. Question 34. You see premature, early, wide, bizarre QRS complexes without preceding P waves in a normal sinus rhythm. What are they? A. PACs. B. PVCs. C. PJCs. D. Fusion beats. Answer: B. PVCs. Rationale: premature ventricular complexes originate in the ventricle, produce wide QRS, and may be unifocal or multifocal. Strategy: identify compensatory pause following a PVC to confirm. Question 35. Frequent multifocal PVCs in an acutely ischemic patient can deteriorate into A. Atrial flutter. B. Ventricular tachycardia or fibrillation. C. Junctional rhythm. D. Sinus bradycardia. Answer: B. Ventricular tachycardia or fibrillation. Rationale: ventricular ectopy in ischemia increases risk for malignant ventricular arrhythmias. Strategy: watch for warning arrhythmias in chest pain patients and escalate monitoring. Question 36. The most accurate way to determine a PR interval is to measure A. Beginning of P to beginning of QRS. B. Beginning of QRS to end of T wave. C. End of P to end of QRS. D. Peak of P to peak of R. Answer: A. Beginning of P to beginning of QRS. Rationale: PR is the onset of atrial depolarization to onset of ventricular depolarization. Strategy: use calipers or count small boxes times 0.04s. Question 37. A narrow complex tachycardia at 160 per minute becomes unstable with hypotension. Best immediate action is A. Adenosine 4. B. Synchronized cardioversion. C. Defibrillation. D. Atropine. Answer, B. Synchronized cardioversion. Rationale, any unstable tachyarrhythmia with a pulse needs synchronized cardioversion. Strategy, look for instability keywords to decide between meds and electricity. Question 38. Which rhythm shows regularly irregular pattern with grouped beating and progressively lengthening PR? A. Atrial fibrillation. B. Mobitz block. C. Sinus arrhythmia. D. Atrial flutter. Answer, B. Mobitz block. Rationale, Wenckebach produces grouped beats due to progressive PR prolongation and a dropped beat. Strategy, when you see grouped, think Mobitz I. Question 39. A wide complex tachycardia at 180 per minute in a stable patient with structural heart disease is most safely treated initially with A. Adenosine. B. Amiodarone or procainamide. C. Atropine. D. Verapamil. Answer, B. Amiodarone or procainamide. Rationale, wide complex tachycardia is VT until proven otherwise, especially with underlying heart disease. Antiarrhythmic infusion is appropriate if stable. Strategy, avoid AV node blockers in undifferentiated wide complex tachycardia. Question 40. A patient's telemetry shows sinus rhythm with ST elevation in 2, 3, AVF and reciprocal depression in I and AVL. What coronary artery is most implicated? A. Left anterior descending. B. Left circumflex. C. Right coronary artery. D. Posterior descending from left circumflex. Answer, C. Right coronary artery. Rationale, inferior MI is often due to RCA occlusion, look for reciprocal changes in lateral leads. Strategy, pair territories with likely arteries for quick recognition. Question 41. In pericarditis, chest pain typically A. Worsens with leaning forward. B. Improves with leaning forward. C. Is unaffected by position. D. Is relieved by exertion. Answer, B. Improves with leaning forward. Rationale, pericardial pain is pleuritic and positional, improving when the patient leans forward. Strategy, when you see diffuse ST elevation plus positional pain, answer pericarditis. Question 42. A nurse preparing to cardiovert a patient must ensure which safety step? A. Deliver shock during the T wave. B. Press sync mode and confirm markers over R waves. C. Use paddles only, not pads. D. Hyperventilate the patient first. Answer, B. Press sync mode and confirm markers over R waves. Rationale, synchronization avoids shocking on the T wave, which can induce VF. Strategy, sync for cardiovert, no sync for defibrillation. Question 43. Which EKG finding suggests pulmonary embolism? A. S1Q3T3 pattern or sinus tachycardia. B. Prolonged PR interval. C. Peaked T waves. D. U waves. Answer, A. S1Q3T3 pattern or sinus tachycardia. Rationale, though nonspecific, acute PE may show sinus tachycardia and S1Q3T3, deep S in lead eye, Q wave and inverted T in 3. Strategy, don't overcommit, on NCLEX, PE clues are more clinical, with EKG supportive. Question 44. An elderly client has new-onset atrial fibrillation with RVR at 140 per minute, stable. Which medication would the nurse expect first for rate control? A. Atropine. B. Beta blocker or diltiazem. C. Epinephrine. D. Adenosine. Answer, B. Beta blocker or diltiazem. Rationale, rate control in stable AF commonly uses AV nodal blockers like beta blockers or non-dihydropyridine calcium channel blockers. Strategy, reserve adenosine for SVT, it won't terminate AF. Question 45. A patient's ECG shows prolonged QT after starting a new antipsychotic. The nurse's best action is to A. Ignore, benign change. B. Notify provider and review medications/electrolytes. C. Give atropine. D. Start epinephrine. Answer, B. Notify provider and review medications/electrolytes. Rationale: prolonged QD increases torsades risk, especially with certain drugs and electrolyte abnormalities. Strategy: think torsades prevention whenever QD is long. Question 46. Which is true about sinus arrhythmia? A. Always pathologic. B. Irregular RR that varies with respiration, otherwise normal. C. Wide QRS with AV dissociation. D. Always requires atropine. Answer: B. Irregular RR that varies with respiration, otherwise normal. Rationale: common benign finding, especially in younger patients. Strategy: if everything else is normal and the irregularity waxes and wanes, choose sinus arrhythmia. Question 47. During CPR, the monitor shows VF. After defibrillation and 2 minutes of CPR, the rhythm remains VF. Next best step is A. Atropine. B. Epinephrine, continue CPR, and defibrillate again. C. Synchronized cardioversion. D. Adenosine. Answer: B. Epinephrine, continue CPR, and defibrillate again. Rationale: shockable arrest cycles repeat, defibrillation, CPR, epinephrine, defibrillation, consider amiodarone. Strategy: know the course sequence for VF/private. Question 48. Which statement about lead placement for a 12 lead is correct? A. Limb leads go on the torso only. B. Precordial leads V1 V6 are placed across the right and left chest at specific intercostal spaces. C. Any chest position is acceptable if consistent. D. Only 4 leads are needed for a 12 lead. Answer: B. Precordial leads V1 V6 are placed across the right and left chest at specific intercostal spaces. Rationale: accurate placement is essential. V1 4th ICS right sternal border, V2 4th ICS left. V4 5th ICS midclavicular, V3 between V2 and V4, V5 anterior axillary, V6 midaxillary at V4 level. Strategy: misplacement changes ST/QRS appearance, suspect if tracings are odd. Question 49. Atrial flutter with variable block will appear as A. Irregular baseline without P waves. B. Sawtooth waves with inconsistent RR intervals. C. Wide, bizarre QRS complexes at a slow rate. D. Regular narrow complex tachycardia at 180 per minute with hidden P waves. Answer: B. Sawtooth waves with inconsistent RR intervals. Rationale: flutter waves are present, variable AV conduction produces irregular ventricular response. Strategy: identify F waves first, then assess conduction ratio. Question 50. A patient in complete heart block becomes unresponsive and pulseless. The tracing shows regular P waves and a slow wide QRS but no pulse. What is the priority? A. Synchronized cardioversion. B. Immediate CPR and defibrillation if rhythm becomes VF/private. C. Adenosine. D. Atropine only. Answer: B. Immediate CPR and defibrillation if rhythm becomes VF/private. Rationale: pulselessness triggers cardiac arrest algorithm. Even if an organized rhythm appears, treat as PEA initially with CPR and epinephrine, defibrillate only if a shockable rhythm appears. Strategy: always treat the patient, not the monitor, pulse check guides the algorithm. You just learned how to simplify EKG interpretation and make cardiac questions way less scary. Remember, practice is what turns knowledge into speed, and speed into confidence on the NCLEX. If you found this breakdown helpful, don't forget to hit like, subscribe, and turn on the bell so you never miss more step-by-step NCLEX strategies. And share this with a friend who's also preparing, because success is easier when we learn together. Until next time, keep practicing, stay confident, and I'll see you in the next lesson.